So let's start with just some basics around the move to managed care. And these are the questions that we thought might be a good place to start our morning together. Why Medicaid managed care? You know, what's so great about this managed care program? What is it I'm hearing about moving from volume to value? There's a lot of conversation about moving from volume to value. What does that really mean as it relates to the Medicaid program? And most importantly, is the managed care, the move to managed care, really going to be better for the folks that I serve? Because at the end of the day, that's what we want to make sure, that the folks are getting the high quality care that we know they deserve. So let's dive in. First, some quick fast facts about Medicaid. Many of you probably already know this, but it is the largest public health care coverage program in the state. Far surpasses Medicare in terms of the number of people served and the spending that the federal government spends. In Illinois, 25% of Illinois citizens are on the Medicaid program, so it's a significant source of healthcare coverage for folks in our state. And about 25% of the state budget goes to spending in Medicare, and that has slowly grown over the years, and it continued to be eating up a larger and larger share of our state budget, a larger and larger share of general revenue funds. And so that was true across many, many states. And so that's why these states started to take a serious look at, we need to figure out a way to manage the cost of and the spending in our Medicaid program, or it's going to start impinging on our ability to put money towards public safety and education and all those other important things that we want to see in our states. And so beginning in the early 2000s, as this, the medical inflation just kept going up and up, you started to see more and more states experimenting and piloting and putting in place managed care programs within their Medicaid systems. So Illinois was a little late. So you can see here, this is the early 2000s. This is nationally. There's just sort of this slow trend. They're just trying a few things, and then after 2011, you start to see a more significant growth and shift to managed care programs. For Illinois, what the rest of the country did in 10 years, good old Illinois, we have to be different, we rammed it in 2 years. So you can see, we really didn't do anything, and that was when many of us were down in Springfield going, hell no, no managed care. We finally lost that battle, and within 2 years, we had put almost the entire Medicaid population in some form of risk-based managed care. Obviously, that created a lot of issues for providers, for the MCOs. I mean, they'll be the first to admit. There were a lot of challenges and issues. The state would admit that, and certainly the providers and the enrollees experienced that. So it was not the best way to do it, but the fact of the matter is, it's here, and we're in very good company, and I think it's here to stay. You can see nationally, almost all states have some form of managed care. The forms sort of are different in different states, but the vast majority of those are really following the Illinois model, or we should say Illinois followed their model, which is full risk-based managed care organization. So the state basically delegating management and financing of the Medicaid program to independent managed care organizations. And 75% of all Medicaid beneficiaries nationally are now in some form of managed care. So I think the train has long left the station. It's not going back. And so I know at the beginning of this process in Illinois, there were still a lot of providers and a lot of groups pushing back and saying, no, see the mess you've made, this isn't going to work. I think that the horse is out of the barn. We're not going to put it back in at this point. And frankly, I think there are reasons to embrace managed care. As I said, I was a strong opponent of Medicaid managed care for many, many, many years. Now, having worked in it, I really do see the benefits, but let's talk about that for a little bit. Why are states moving to Medicaid managed care? Obviously, one of the biggest things for states, remember we talked about that cost inflation, the spending continuing to grow year over year. With managed care, you have some budget predictability. If you think about the fee-for-service system, the state really had no way to predict spending year over year. It was basically, you give Medicaid eligibility to folks, they go to doctors, they go to emergency rooms, they go to their pharmacy, and the state just paid for all those claims that came in. they had no way of knowing how many people were going to go to an emergency room in a year, how many people were going to be hospitalized, and for how long during a year. So they really had no way of knowing year over year what their budget was or any control over that. They just were basically paying the bills. When you put in a managed care program and you are paying the MCOs on a capitated basis, and Angela's going to talk a little bit more about this in a minute, you know you've got 3 million Medicaid enrollees, and each of them have a certain monthly payment that you're paying the MCOs. You know year over year, this is how much my budget for Medicaid is going to be. So you're paying the MCO a flat fee every month for that Medicaid enrollee, and then you're done. It's up to the MCOs to figure it out from there. And so you have that budget predictability. Make sense? The second reason that states moved in this direction was really program savings. When they create a managed care rate, so they use experience and claims data and stuff and come up with that monthly per member per month. You're going to hear us talk about PMPM, per member per month. As they come up with that rate that they're going to pay the MCOs, they actually say it's going to be, we've come up with $100 per member per month, but we're going to pay you $98 per member per month because we're building in savings. We want to see the cost of our Medicaid program go down. You're supposed to be doing all these great things and coordinating care and creating savings for us. So they actually build that into the rate. So they know they're going to see some savings year over year in the Medicaid program. There's a lot of controversy and a lot of different studies that say a lot of different things on how much Medicaid managed care actually saves states. There's a meta-analysis, a synthesis of like 24 different studies around this that say states can achieve up to 20% savings in their Medicaid program. Even if they just do pharmacy, they just include pharmacy in the managed care program, they can save up to 15%. Whether that's true or not, and we still, it's still too early in Illinois to know how much we've actually saved. I think the premise and the theory behind it and the fact that they're building in that savings every year, I think we can make some assumptions that it's going to save the program money over time. It's still out for debate, but that is the premise. And finally, managed care really aligns more with quality. If you think about a fee-for-service system where you're just paying the bills and people are going to doctors, you don't really have a way to manage quality to ensure that Medicaid enrollee is getting the preventive screenings or getting the behavioral health counseling services they need or getting the appropriate care in the appropriate place because you're just paying bills. You're not managing the care that they're receiving. Under a managed care program, you have much more control over that because you can tell the MCOs in their contract, we expect you to measure these 3 or 4 or 5, it's much longer than that. It's like 15 or 20 things that the MCOs have to measure to ensure that those Medicaid beneficiaries are getting those screenings. So they every year have to be tracking how many mammograms for appropriate women were received, how many colorectal screenings, were your kids immunized? All those things that under a fee-for-service system they weren't really tracking. Now they build it into the MCO contract. So they have a much better way of ensuring a quality outcome for the Medicaid enrollee. And they actually build that into financial incentives for the MCOs. So on the right-hand side, you can see some of the ways states incent or create an environment where MCOs really want to focus on quality. And actually, Illinois uses all of these methods. So they have a capitation withhold. So like I said earlier, if the capitation rate was $100 PMPM, what they will do is they'll say, okay, Illini Care, the capitation rate that we've come up with is $100. You're going to get $95 throughout the year, every month, for that beneficiary enrollee. But if you can show that that child got all their immunizations, or that woman got the mammogram, or that person that was hospitalized had follow-up in appropriate amount of time, you can earn that extra $5 back. So the incentive for the MCOs is, the rate is $100, we want to make sure we get the $100, so we're going to have to ensure that we meet these quality metrics as we go through the year. So that's called a capitation withhold, and that's something that Illinois has done for a number of years now. The other thing that they've done is moved the algorithm for auto assignment. As you may know, and Angela will talk a little bit about this in our eligibility section. If a Medicaid beneficiary doesn't actively choose a plan, the state will auto assign them into one. And they will create a preferential algorithm for those plans that demonstrate better quality. So again, the plans are very much incented to make sure that those quality metrics are met, because it gives them a leg up in terms of the members that will be auto-assigned to them. That's something else that the state of Illinois does. And finally, publicly available comparison data. You know, the HFS website now has very clear report cards for the MCOs for things like patient satisfaction. Are they meeting the HEDIS metrics that they're on the hook for? Provider satisfaction. So all of that is now publicly available, which again, really, I think lifts all boats in terms of quality and value for the program and for the beneficiaries. So that's the premise behind why we've seen such a large shift into managed care. So the bottom line, and we're going to bring up someone who can talk to this in a little more specificity from a provider perspective, but really when you think about the theory of managed care and in the Medicaid program, the overall goal is to keep the patient healthy. Because if you're an MCO and you have a fixed amount that you're getting paid every month for that beneficiary, so if it's $100, you want to make sure that that patient stays healthy by using primary care services, making sure they pick up that prescription, making sure they get to that counseling or substance use disorder session. Because if they don't, and you deny that care in any way, they're going to end up in a much higher level of care. They're going to end up in the emergency room. They're going to end up having to be hospitalized for a certain amount of time. They may end up in a nursing home with significant rehabilitation costs. So you're very much incented to make sure that that patient is getting the services and the quality services that they need. You become much more a partner with the provider community, because the providers also obviously want to see quality services delivered. So that's really the premise and the theory behind it. And you can see that really at the goal is always the patient. So it really focuses the work of all the providers and the MCO on keeping that patient healthy. If you deliver quality care, your costs are going to come down automatically. Good quality care always will cost you less than poor quality care.